Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the article Superiority of the Triple Combination Bortezomib, Thalidomide, and Dexamethasone over the dual combination Thalidomide and Dexamethasone in multiple myeloma patients progressing or relapsing after autologous stem cell transplantation. These results are derived from the MMVAR-IFM 2005-04 randomized phase 3 trial from the Chronic Leukemia Working Party of the European Group for Blood and Marrow Transplantation. This paper was published by Laurent Gauderet and her colleagues. My name is Dr. Paul Richardson, and I am the Clinical Director of the Jerome Lipper Multiple Myeloma Center at Dana-Farber Cancer Institute in Boston, Massachusetts. My oncologic specialty is multiple myeloma. I am here today to provide you with a podcast providing a critical evaluation of the combination of bortezomib, thalidomide, and dexamethasone in relapsed multiple myeloma. This prospective multi-center phase 3 study compared the efficacy and safety of a triple combination, specifically bortezomib plus thalidomide plus dexamethasone, versus a doublet, thalidomide plus dexamethasone, as a relapsed refractory salvage strategy in patients progressing or relapsing after an autologous stem cell transplant. This multi-center randomized trial enrolled 269 patients. Patients received a combination of bortezomib, thalidomide, and dexamethasone for 1 year versus a combination of thalidomide and dexamethasone as the comparator. The classic bortezomib schedule was followed on days 1, 4, 8, and 11 with a 10-day rest period, and this was utilized for 6 months with maintenance following for a further 6 months on a day 1, 8, 15, and 22 schedule every 42 days. Excitingly, the median time to progression as the primary endpoint of the trial was significantly longer for the 3-drug combination when compared to the 2 drugs, at 19.5 versus 13.8 months respectively. And commensurate with this clinical benefit, both complete and near-complete response rates were significantly higher for the 3-drug combination versus the 2, at 45% versus 25% respectively. And I think it's important to note that this is a particularly promising result in a relapse setting. Not surprisingly, the median duration of response was similarly longer in favor of the 3-drug combination. Interestingly, the overall survival estimate at 2 years trended in favor of the 3-drug combination as well, which again supports the benefit of this approach. Having said that, one caution was the increased rate of grade 3 peripheral neuropathy, which was more frequent with the 3-drug combination versus the 2, as were the rates of grades 3 and 4 infection and thrombocytopenia, emphasizing the importance of appropriate management of side effects, as well as the need to look for the less neurotoxic regimens or look to less neurotoxic regimens as being an important option in the future. The authors overall therefore correctly conclude, in my opinion, that the 3-drug combination of bortezomib, thalidomide, and dexamethasone in this prospective randomized trial was more effective than the 2-drug combination of thalidomide and dexamethasone in the treatment of myeloma patients relapsing after autologous stem cell transplant. As mentioned, significant toxicities included neuropathy, and this remains obviously a key challenge going forward. In terms of future directions, this important phase 3 trial serves to illustrate the value of the combination of an immunomodulator and a proteasome inhibitor in the management of multiple myeloma in the relapse setting, and also supports the very promising results recently seen with this combination approach up front in newly diagnosed myeloma. Interestingly, both treatment groups in this study were similarly balanced for prior bortezomib exposure and thalidomide use, suggesting that the combination of the 2 drugs used at relapse is actually a viable strategy for treatment. And this supports previous observations where re-challenge with the same classes of drugs, but in combination, can restore response despite treatment failure from the same classes of agents used separately before. I think, therefore, to have this observation validated in the setting of this phase 3 trial is particularly helpful and should further reinforce this approach in practice as we think of innovative ways to treat relapsed and relapsed refractory myeloma. In the same context, a similar degree of efficacy for the 3-drug combination was apparent in those patients who had more than one autologous transplant versus those who received one transplant alone. In addition, the higher efficacy of the three-drug combination was clearly observed even after adjusting for factors for high-risk disease in particular, such as advanced age, elevated beta-2 microglobulin, and adverse cytogenetics. This latter observation again supports prior studies in which bortezomib-based therapy has been shown to provide additional benefit in both favorable and unfavorable prognosis patients. Whilst no statistically significant difference in overall survival benefit is yet apparent, there is a trend, and I suspect longer follow-up will be important in this regard. Certainly, the likelihood of survival benefit seems high based on prior trials in relapsed disease where both the quality of response and progression-free survival advantage have generally correlated well with overall survival. Further, a vital consideration going forward will be that of reducing toxicity. In this regard, the substitution of lenalidomide for thalidomide is an obvious step, given the significantly reduced neurotoxicity associated with the use of the former. Similarly, considerations regarding the dose, route of administration, and schedule changes to bortezomib to further reduce neurotoxicity will be important. Finally, second-generation proteasome inhibitors hold the real promise of being substantially less neurotoxic and thus should be important options in the years ahead, provided current ongoing trials confirm their potential. This concludes this JCO podcast, and thank you very much indeed for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.